Welcome, guys, to episode 7 of the Misfits Podcast. We know you've
Yay.
been wanting to get your weekly fix in on the boys, and we're back.
Yeah, the boys and Raymond.
Yeah.
Okay,
season
bro.
pass.
Okay, would you like
I
to
guess that's
introduce
what
yourself?
separates the boys from the men. Me.
I hate this. Okay.
Okay, so would you like to introduce yourself, guys?
Okay. I'm Manas.
We'll let the
Yeah.
boys speak first.
Yes.
Okay, I'm Brendan. Nice to meet you again, guys.
And I guess since I'm not one of the boys, I'm one of the men. It's your man, Raymond.
Okay, thank you, Raymond. Okay, so what we're gonna talk about today? I know Raymond, you've been doing quite a lot of preparation for the Oscars. Can you tell us a little bit about that?
Well, what if you mean by preparation, feeling anxious, uncertain, and what's another word to describe myself? Help me, please.
An idiot.
Oh, you walked into
Anxious,
that one.
uncertain, and an idiot. Yeah, those are three feelings I have
Yo.
when thinking about the Oscars. So,
Yeah, that's true.
what do you do when you're in that situation? Well, either you sit there and you become consumed by the fear of the oncoming hurdle, or you consume the fear. And how do you do that? Well, it's preparation. Like Brendan said, I've been doing a lot of preparation recently, and I've been setting up studies and sessions for us to prepare for the Oscar. So I just book a room and call out a bunch of friends to hang out in some of the rooms, and we practice on each other. Been going through some of the history and examination that we've discussed in previous episodes, such as the gastrointestinal examination, where you press lightly and heavily and you feel for all the organs, right? We've talked about that. But then another thing that we need to be doing is going through some of the DOPS. So by DOPS, I mean the clinical skills that we've also been discussing previously. So for example, looking at our basic life support, or our venipuncture skills, or injections, for example. One problem or challenge that we need to overcome is that there are a lot of resources in the medical school rooms, but they don't have the resources to practice these DOPS. Would you agree, guys?
Yeah.
Yep.
I think it's hard for the uni to also source a lot of these things in the first place, because it's like, if they're just providing it to students just like for them to use, you need someone to supervise them as well, because there are a lot of like dangerous objects such as sharps that are liability for the people, running the medical faculty, right?
Another thing I think of is the amount of resources being consumed. Imagine if every time you practiced, you used 2 wet wipes, you used like 3 needles. That's a lot of resources being used for one practice, and then you multiply that by hundreds or thousands of times people are practicing, and then that's adding into the budget, right? That increases the fees that domestic and especially international students will have to be paying. But another way of preparing is by doing mock OSCEs. So I've heard that some others have been organizing mock OSCEs, especially the UQ Medical Society, for example. They have organized a mock OSCE later this month, and I actually forgot to buy a ticket. So that's kind of unfortunate. Tickets are sold out.
There's limited spots.
Yeah,
Oh my god.
that's the thing. It makes sense because they're practicing it at Hurston, which is where we do our clinical skills, where the injections and needles are all at, like where all the resources are at. But at the main campus at St. Lucia, you don't have any of them, and that's where we are, right?
Right.
However, if you can't get a ticket, why not just make an OSCE yourself? And this is the part of the podcast, the segment of the podcast where I shill what my friend and I have been organizing. Brendan, you know her well, right?
Yes, I do. Good old Vic, or Tori,
Yeah.
as we like to call her. Guess what that stands for? Victory in the cat and the OSCE.
Yep.
Damn. Okay.
Okay, but yeah, I hear you guys are like organizing a mock OSCE that's happening, fairly soon with a bunch of stations.
Yeah.
That sounds pretty promising.
We'll see how it goes. And we have multiple ideas and concepts that we'd like to apply. And one idea we have is maybe keeping it up for the long term. So not just for this OSCE, but more for the lifelong learner aspect that the medical school has been talking about. Because what's the point for practicing for one single DOPS where you get assessed, or a single CAT where you get tested on, or having all of your clinical skills, your health and examination skills being tested on one OSCE just for you to forget, right? There's statistics out there where the competency of drivers increases the closer one gets to the P plate test, right? But then it drops significantly after people get their P plate. And we know why, right? We're not being assessed anymore on our driving skills. We're just applying it in our day-to-day routine. For example, I've got my P plates, but I haven't driven in years consistently, at least. Like, I might drive maybe 10 times a year, but I wouldn't feel confident enough to go on the road and drive you guys, for example, because I don't feel like it's fair for your lives to be in my hands when I'm not the most practiced out there. So I think the same applies here with these OSCEs, where it'd be good for us to have some sort of continuous assessment, whether it's formal or whether it's something organized by us, right?
Yeah, that's true. But do you think there's any like limitations to doing this sort of like MOSCE practice? Like, for example, sometimes the people we're practicing are like fellow students, right?
Yeah.
So, do you think that would kind of influence the way that we do examinations? Like sometimes we'll say things that we expect like the patient to understand, but since it's medical students, they're like, oh yeah, I know this term, but maybe it's a bit confusing for people who aren't in the same field as us, right? And there's also the sense of familiarity, because then you know that you're performing this examination on someone that you already kind of tangentially know or even like know well as a friend. So then you don't have the same like nerves that you get when you're meeting a patient who's like different in like culture, background, occupation, age, right? Because we're similar in the med corps, at least there's a diverse range of people, but in the end we're still quite a similar group in comparison to the patients we'll see in our eventual future practice.
That's actually very true now that you bring up that point. I didn't consider that when trying to organize this mock OSCE, that our age range is, well, for students that are postgraduates, right? So I think they're between about 20 and 30 years of age, the majority of students in this cohort, while the patients that we may meet in the future, or patients that some people already meet now, like they are from birth to elderly and those that are about to pass away. That is something definitely to consider. And when thinking about limitations, I would agree that is a limitation to what we're trying to organize here, where the patients might not represent, or the mock patients might not represent real patients. While we can say that a student should pretend to be a 50-year-old person, while they might try to act in that way where they change their voice, tone, and body language, maybe they aren't able to fully emulate it based on appearance, for example. Like, I wouldn't, like, how old would you say I look, for example? Be
50.
honest.
20. Let's see.
Yeah,
Okay.
so I might look 20, so I might
Really?
be able to play off a role of someone who's 20 or maybe between, let's say, 15 and 30, but I'm not going to be able to, I don't look like someone who's 50, right? So when you walk into a room, what you see versus someone's appearance, you might hear someone talk outside the room, but you might, like, that's the first thing you see, right? When you walk into the room. So in these OSCEs, or when you walk into the room and there's a patient there, for example, that's the first thing you're going to see. It doesn't matter if you have the patient's records before you walk into the room, or maybe their vital signs at the end of their bed. Like, if the person in front of you looks a certain age, it might give you a different sense of feeling. And additionally to what you said, where there may be the sense of familiarity, I think that might be able to be mitigated by bringing in people that are outside the first year medical school cohort, at least. Like, I don't know too many people who are outside the medical school cohort, at least for first years. And that can be a benefit because that adds to the realism of meeting someone completely new for the first time, who is someone that you will work together to improve their health, for example.
I guess another thing that that might be worth taking into consideration is that if we are trying to emulate a patient who's like not us, maybe they're like maybe we're pretending to be like an elderly, maybe we're pretending to be young, maybe we're pretending to be, I don't know, whatever. We don't want to help contribute to stereotypes that might already be established.
That is
So like, and that'll be especially important considering and if we are like having implicit or explicit, hopefully not explicit, but if we are demonstrating implicit like bias and as a result demonstrating some kind of stereotype when we're simulating a patient, we don't want to get used to those type of stereotypes when we're practicing on each other.
Yeah.
Because then that might be something that it's ingrained to us, and that might end up being something that we demonstrate in front of the examiner in the OSCE, or worst, like hopefully this isn't the case, maybe like no one sees and we end up becoming doctors, and then we start demonstrating those in the actual clinical environment. So I do feel like there is like a pro in the sense that if we do notice stereotypes during our MOSCEs and during our practice sessions, we can sort of identify them amongst each other then and there and deal with them then and there, as opposed to maybe doing our first time history examination in front of an examiner or in a clinical environment, and that's the first time it's picked up and we're like, oh crap, why did we not ever find this out before? But yeah, it's just one factor that might be important to take into account.
Oh,
I think that I think that that's more of a reason to have that lifelong learning, to have something organized where we can practice our clinical skills throughout the year, not just for these assessment deadlines, but have something steadily going in the background. Maybe once a month we have a mock OSCE done in the medical school that can be just organized by the students, and maybe in between each of these mock OSCEs maybe we just have one session to refresh ourselves on anything that we want to highlight, for example, where maybe we just focus on one particular examination once a month and we just go through it in half an hour, or to be efficient we can go through 2 or 3. But the point of all of this, just to go back to the main point, I think that having this lifelong learning, having this ability to practice our skills and not just keep it in our heads, is something vital to being a good practitioner.
Yeah, and actually, when Manus, you raised a good point when you were talking about stereotypes, right? I was thinking, like, it's true. Like, there are a lot of like stereotypes that we have in our own like implicit biases, explicit biases, and so on, right? But
Mm.
the fact is that a lot of medicine, a lot of the applied clinical medicine, like you hear from in tutors in H&E, is actually based on like a little bit of stereotyping, right? It's like,
Mm.
oh, for example, certain types of like blood disorders found in this certain population, right?
Right.
Or this sort of disease is found normally in like older individuals. Like, older people are more likely to develop this cancer, or this is usually discovered in younger people,
Right.
or specific like race-based medicine in a sense, right?
Yeah.
So I think it's good that you raised that point, Manus, because we have to be aware that even though we have all these like rules of thumb, like these heuristics, like, oh, if I see this patient, you immediately like class them in like, oh, okay, like maybe they're, let's say, I know like African American people are said to be more likely to have hypertension, for example, right?
Right.
You go like, oh, they might be hypertensive, there might be something that I have to look out for, right?
Right.
But that mindset that medicine is training us to do, like to apply our clinical knowledge, is also feeding into our own bias.
Mm.
And that's how a lot of like medical, I guess, malpractice, or just like how the patient gets like drowned out, like the noise of their like characteristics, like, oh, socioeconomic status is like low, they live in like a crowded environment, they're more likely to get like this, like, or the stuff, especially the indigenous Australian or like Aboriginal and Torres Strait Islander workshops that we've had. We've seen these people being classified in certain ways, like
Mm.
frequent flyers, non-compliant, that sort of thing. So
Right.
I think that's a very good point that you raised now.
So essentially, I think you did make a good point developing that. Essentially, we want to be aware of the risk factors that certain patients might have based on their demographics, but we don't want to class them into it or categorize them or objectify them to the point that they're no longer a person, and to the point that we only see the risk factors in them as opposed to the actual person that they are. I guess yeah, that's it.
And I think
What are
like,
you saying?
oh no, I think doing like practice histories is kind of helpful for that in a way,
Right.
because sometimes you read the history and they're not always like the way that you expect them to be, and you kind of get a view inside their lives. Oh, like their occupation, they have hobbies, they have a life outside of just being a patient. How are you finding history taking, like social history taking, or like just history of presenting complaints?
Okay, well, I'll go first, Manus.
Yeah.
When thinking about the history taking, I think that some feedback I am continuously getting and that I've found is a common theme for myself and maybe for others is to keep asking more questions, to keep probing deeper and keep asking why, or ask the patient for more information, because a patient might give you an answer, but unless you probe deeper and ask follow-up questions, you won't know the full picture. Then that may cause or misdiagnoses to occur, which is really bad. For example, like, I don't know where I'm going with this.
Oh no, I think that's a good point, Raymond. As in, like not asking enough questions, like not getting to like the bottom of seemingly insignificant details, is a really big deal. Like I think one thing that I often miss is like associated symptoms, because sometimes you hyper focus in on a particular problem that the patient has. I remember one scenario was, I remember being asked a question about a patient who was experiencing dizziness, right? And then I just like barreled on about like, oh, like how's the dizziness? Oh, this was like the first time I got it, like ever had it. It lasted for 15 seconds. so I haven't really taken anything to alleviate it. Nothing's really made it worse, right? And I'm like, there's nothing here. Like, I can't, like, this guy has only experienced this dizzy spell once. And then I'm asking all these questions that you normally see in like Socrates, and half of them don't apply, right? Because you already know the onset, when it happened. It wasn't doing anything special, that sort of thing.
Could you explain what Socrates is for those?
Oh
that
yeah,
may not
so
know?
Socrates is basically an acronym that us medical students have been taught to structure our history taking, right? However, it's very pain focused. So it goes site, onset, character, radiation. I guess I can explain it. So site, like where it is. Onset is when it happened and what
When
you
it
were
started,
doing while it happened. Character is what type of pain it is, like burning, stabbing, like a dull pressure. Radiation is if the pain spreads to any other part of the body. Alleviating factors is for like whether anything makes it better, like medication or rest, for example. T is for timing, so does the pain like come and go suddenly? Is it constant? Does it come at specific times of the day, like before a meal or at night? And S, wait no, for E, exacerbating factors. So just things that make it worse, right? And S is for severity. So it's normally given as a scale of 1 to 10. Where 1 is the least pain you've ever felt, and 10 is the worst pain. Yeah, but since it's very pain focused, for this dizzy spell question, it's a bit hard to apply. But when I started asking about associated symptoms, it became a lot more clear. Like there was like other stuff going on, and I was just like hyper focused on one like symptom.
That's a. I wouldn't say it's a weakness of Socrates. It's just something that isn't included in the acronym. So that's just something you need to keep in mind when taking someone's history, obtaining someone's history, because it's important to remember patients have autonomy. So we're trying to transition from older terms such as adherence to compliance, for example, where
I think it's the other way around.
Sorry, thanks for correcting me. When patients transition, we're trying to transition from terms like compliance to adherence. So we're trying to say that patients have their own autonomy.
Yeah, thanks, Brendan.
But let's talk a bit more about the social history, because our assessments on how well we can take someone's social history is happening this week. How are you guys feeling for it?
It's not too bad. I mean, for the most part, there's no like physical examinations involved. It's probably, I don't want to jinx myself, but I imagine it's going to be one of the easier mini CEXs to do. Okay, I skipped a future me saying it was the worst thing ever. But in any case, I think one thing that slightly worries me is I think Brendan, you mentioned this earlier, was like the idea of hyper focusing on something. I know during clinical comms, which was sort of similar to the social history taking mini CX, because we had to still take somewhat of an initial social history and then find out what the issue was, and then we had to suggest some ideas for how we might be able to help the patient get out of the rut they might be in. Maybe it's something to do with diet thing, maybe it's something to do with mental health, and maybe we can sort of suggest them, have you considered seeking out professional help, or have you considered talking to people that are around you to maybe get their help as well, and they can aid you in something. But the issue is sometimes during our simulations of social history taking and that aspect of giving ideas to help someone, we would sort of get stuck with red herrings. So I know one time there was a simulated patient of, I think, like a teen, and one of the things they mentioned was they had a headache, and they were taking some, like they've tried taking some like some type of like paracetamol or whatever to try to help it, and some other random medication. And we as sort of a group started going a little too much into asking about the medical history in terms of drugs, because we started thinking maybe they have like some kind of like drug sort of a substance issue or something like that. And that was, I think, like a assumption that we made based on like this one random piece of information that they provided. And that was a complete dead end. And we were all sort of clueless about where to go after this, because we we have to find out what the technical issue is before trying to figure out how to help them. You can't help them if you don't know what the issue is. And so our tutor was like, maybe you should ask them about their life at home with their parents. And so we did. And then she started talking about like potential abuse. And we were like, yeah, we took the complete wrong direction with this. So until you actually figure out what the issue is, you can sort of get lost in what questions to ask and how to transition between different like areas of the social history, taken from diet to mood to exercise to lifestyle and relationships and house. So that's just one thing I'm scared about. But other than that, hopefully it should be okay. Fingers crossed.
Yeah. No, as in, I totally agree, man. As in, it's a bit tricky because it's kind of like you don't know what social history you're going to get, because then
Right.
they say that it's going to be a focus on nutrition or on mood, right? So if you spend too much time wallowing in the wrong streets, right? You're like, oh, maybe it's related to diet. This diet sounds pretty unhealthy. And all of a sudden you spend like 4 minutes just like yapping about diet, right? Like, oh, what did you have? What snacks do you have? Oh, are you sure you told me if you're snacking during the day, right? And then boom, they come out and they're like really stressed about it, like during work, and then they're like eating to like compensate for or something. You're like, oh, completely missed it. And you've only got like 1 minute left to basically uncover this whole guy's story, right? Which is not great. And mood is such a hard thing to fit in a small space of time, right?
Yeah.
Normally a psychologist appointment would be closer to an hour than 6 minutes, right? So that's not a lot of time for us to kind of, get to the bottom of a patient's like problems and see what it is that's like causing them distress or pain. And to do that while also not knowing what the focus is also like a bit hard. And I guess this might also be a little bit of it's both a blessing and a curse, because this focus on like either nutrition or mood kind of pigeonholes you into like two routes, because you kind of like lock in, oh, it must be a nutrition problem or must be like a mood problem, right? Which can be a bit harmful in our future practice, because we might start to just prioritize certain things more than others because we've like seen it before. Like, oh, I've seen this is probably like a mood. But it's good in that in real life, patients will not signpost what kind of like illness they have, right? You just take the history and then there can be like a multitude of factors. It's not like we go in that they're like, oh, I am a respiratory patient. I'm going to give you a history now, right?
Do we have anything else to add?
Well, I'm just thinking about what Brendan has said, and I think it goes back to biases that we may have from what we come across, whether that's in our daily life or whether that may be in medical school. I don't remember what type of bias it is, and I will need to check up on that because that's something we've learned, the types of biases. I'm referring to the one where you learn something relatively recently, and then because of that, you might think a case you come across right now is the same as what you've come across recently.
The like anchoring bias or like recency effect or something?
I think it's the recency bias.
Or it's like the primacy, because I don't know, it's one of those two.
It could also be framing effect.
Framing effect.
Because it's like the situation makes you think of something that happened before. So it's like, oh, similar circumstance.
Like, I do agree with the pigeonholing between mood and diet may be harmful in future practice, because I think we need to remember that patients have their whole lives that they interact with. Like, everything in their life will impact everything, right? It's not just having 10 good aspects in life and then all of your problems are to do with one thing. It doesn't work like that, right? When someone is going through an event or has an experience that might not be the best, it will impact on everything else, and vice versa. If you don't have a good diet, for example, that would affect your mood, right? It might just be food that you don't like to eat. It might be healthy, but if you don't like to eat it, then your mood's not going to be good, right? So I think we need to think about, like, we always need to keep the whole person care in mind, not just a tip or trick or piece of advice that our tutors may say. While that may be good, remember, it's one person's perspective, it's one person's point of view. So we need to be open-minded when coming across this information from the past to the future.
Yeah. That kind of reminds me of, like, remember when Yo-Yo was on the show, right? And then we were discussing.
Yeah, she was great.
Yeah, it was great. And we were discussing, like, what's your least favorite, like, part of medicine, right? Like, least favorite subject.
Okay.
And then we were, like, discussing, like, climate change. We can't really see how it connects. And now just talking about, like, how everything kind of leads to who the patient is, and what problems that they're experiencing, right? I think maybe considering climate change, these little, like, factors that can lead to food
Insecurity, right?
Food insecurity, also, like, different weather changes, maybe their job is being threatened. I think that's, like, important to know.
Yeah,
So-
all that extra stress and anxiety, which is affecting your mood, right?
Yeah.
Everything counts, and I think that's something we should remember when we go forward, not just as doctors, but as people.
Facts.
So true. And I think that's a message that our viewers would do, or listeners would do well to take away from this podcast. So thanks for listening, guys.
Thank you.
Bye. I don't know how else to end it, man. This was-
Okay, well,
you know-
thanks
okay,
for
Valentine.
listening, guys.
As your punishment, you have to tell them to like and subscribe.
Like,
Right now.
subscribe, smash that like button, comment down below what's your favorite part of this podcast. We probably won't see it, but you
I
probably-
will see it because
Okay,
We
maybe,
will
okay.
see it.
it's on my channel.
Yeah, that's true. Okay, we will see it.
And don't forget to ring that notification bell.
Yes, ring the notification bell.